Hi, everyone. My name is Hope Avalone, and I'm the Senior Manager of Patient Education Programs here at the Lymphoma Research Foundation. It's my great pleasure to welcome you to our update on diffuse large B-cell lymphoma webinar. During today's webinar, you'll hear from lymphoma specialists, and you'll have an opportunity to ask questions. You can ask those questions at any time using the Q&A box at the bottom of your screen, and any questions you submit through the Q&A box will be able to be made anonymous. At the end of the presentations, we'll address as many questions as we can, and as a reminder, this webinar is being recorded. And at the end of the program, you'll be prompted to complete a program evaluation. We do ask that you complete this brief evaluation as we like to incorporate your feedback into future programming. Before we get into the presentations today, I'd like to share with you a few brief words about our organization. The Lymphoma Research Foundation is the largest nonprofit organization that focuses specifically on lymphoma and chronic lymphocytic leukemia. Our mission is to realize the promise of science to eradicate lymphoma and to serve the community touched by this disease. And all of our work is led by our Scientific Advisory Board, which is a group of 45 leading lymphoma experts from around the country. And in addition to today's program, the Foundation has many other programs and services available for you. We offer both in-person and virtual programs so that you can continue learning throughout the year. Our in-person programs include our Lymphoma Talks, which are weekday dinner programs, and our virtual programs include our webinars like this one, our Ask the Doctor About Lymphoma series, our Living with Lymphoma program, which I'll speak more on in just a moment, and lastly, our Educational Forum on Lymphoma, which is our largest two-day program that takes place every fall. So to view specific dates for any programs, you can always visit lymphoma.org/programs, but I would like to specifically highlight our upcoming Living with Lymphoma program, which is a free virtual half-day program on Saturday, April 19th. So Living with Lymphoma provides detailed information on specific lymphoma subtypes, as well as supportive care topics. We are on a new platform this year, where you'll be able to join community discussions and connect with other patients and care partners. So to view the agenda and register if you'd like, you can always visit lymphoma.org/livingwithlymphoma. In addition, the Foundation offers a wide range of support services as well outside of our programming. So our helpline, which serves to complement our patient education programs, is a resource for both patients and care partners. The helpline has master's level trained staff who can provide individualized information on all types of lymphomas, as well as treatment options, clinical trial navigation, and connections to resources such as financial assistance. We also offer a peer support program called the Lymphoma Support Network. And through the Lymphoma Support Network, we can connect patients and care partners with others who have been through similar experiences for emotional support. Foundation also offers comprehensive disease guides and fact sheets, which can be ordered or downloaded for free on our website at lymphoma.org. And please also look for us on YouTube as well, where we spotlight different lymphoma subtypes and treatment options. And finally, I would like to also highlight our Spanish language resources for those of you who would find information in Spanish helpful. I would also like to take a moment to thank our program supporters. Thanks to their generosity, we're able to host programs like today's webinar. But for now, we have a wonderful program planned for you today with two excellent speakers, Dr. Matthew Lunning and Dr. Connor Johnson. I'm so honored to introduce our first speaker, Dr. Matthew Lunning. Dr. Lunning is a hematologist-oncologist at the University of Nebraska Medical Center, where he is also an associate professor in the Division of Hematology-Oncology. He also serves as the Assistant Vice Chancellor of Clinical Research and the Associate Vice Chair of Research in the Department of Internal Medicine. Dr. Lunning, we're so thrilled to have you on this program today, and I'll now turn the talk over to you.
Well, thank you very much, Hope, and good afternoon, everybody. It might be evening or morning, depending upon where you're at in the world here. Well, I get the great pleasure to present with Dr. Johnson here. We were just talking about how he looks exactly like Tom Cruise, and his call sign is Maverick. So I will be his goose to Maverick today and lead us off as we take off on this adventure going through diffuse large B-cell lymphoma. And so with that, I'm going to share my screen because I still get to see Hope here. And let's see if it works. And I think it worked. Do I have a confirmation for takeoff? All right. She even gave the thumbs up. So we're going to take off the aircraft carrier now and talk about large B-cell lymphoma. And I tried to give this talk some perspective as the oncologist and tried to say, if I was in the other chair, so across the room, I think it's always great, when you have multiple brains in the room. So I know there's some caregivers also here today trying to learn about large B-cell lymphoma. And with that, I will just call out my disclosures as I do research in the space of non-Hodgkin's lymphoma, but also work with sponsors to make sure that they're bringing the right trials to the patient population in need. And so here are my objectives today. We're going to go through talking about, what is the incidence and prevalence of non-Hodgkin's lymphoma, with noting that large B-cell lymphoma is our most common non-Hodgkin's lymphoma, then digging into why we do what we do with regards to the diagnostic approach, and then how best to stage, because stage really matters in non-Hodgkin's lymphoma. And sometimes the stage, that you hear, you can't associate with other cancers. And then we are really at a paradigm shift in regards to the management of non-Hodgkin's lymphoma, specifically diffuse large B-cell lymphoma, where we have a lot of new agents and a lot of shuffling of the deck and different chess pieces on the board against our adversary. And so with that, looking at 2024 estimates in regards to not only non-Hodgkin's lymphoma, we're seeing about 80,000 new cases. And so that is rising in incidence, but we're actually seeing a decline in deaths. There is also Hodgkin's lymphoma, which represents about 8,000 cases. And I get a lot of questions about what is Hodgkin's versus non-Hodgkin's lymphoma. So I put it up here just to start off. So Hodgkin's lymphoma was kind of the first lymphoma that was diagnosed, and then everything after became non-Hodgkin's lymphoma. And so there's now over 60 different subtypes and growing of non-Hodgkin's lymphoma. And so why are we seeing more lymphoma in 2025? Well, I have some postulations here. So if you look for it, you might find it. So when we used to do just physical exam or chest x-rays, we're now turning to more modern modalities of looking for things. And that namely is CT scans. So CT scan availability is replacing a lot of other modalities radiographically where we wouldn't necessarily be able to see enlargement of lymph nodes. We're also seeing a lot more random biopsies on procedures. You come across something on a skin lesion or a colonoscopy or an EGD that may lead to a biopsy. And then we're also seeing a lot more kind of welcome to Medicare, where you get a complete blood count. You may see an elevated absolute lymphocyte count, and that leads to further testing. But also, I think we have to realize that we're living longer, and so we have with better control of hypertension, diabetes, high cholesterol, as well as better technologies in regards to the management of acute myocardial infarction and stroke. We are, seeing people living longer, and probably one of the biggest risk factors for getting a lymphoma is actually living longer from those regards, despite some of the other risk modifications that you may be not with that are within your control, like smoking, alcohol intake, and so on and so forth. So one of the things we should know about the diagnosis of non-Hodgkin's lymphoma is that not all lymphadenopathy or abnormal sized lymph nodes is lymphoma. We have to respect that infections can lead to enlargement of lymph nodes, and specifically mononucleosis. You can feel my neck, and I have some shoddy lymphadenopathy from when I had mono when I was 19 years old. Also, strep throat can lead to not only enlargement of the tonsils, which is a lymph node, but also some enlargement of the neck lymph nodes, as well as some other, infectious disorders. Other malignancies may manifest as enlargement of lymph nodes, so regional lymphadenopathy from breast cancer, or some inguinal lymphadenopathy from prostate cancer. Also, inflammatory conditions like sarcoidosis, as well as other autoimmune conditions. I already saw a chat question there about talking about autoimmune conditions. So conditions like Sjogren's can even lead to kind of atypical or enlargement of lymph nodes. But if it persists, I think that is something that should be brought to your local primary care doctor to be assessed. So two most important initial questions in non-Hodgkin's lymphoma is why do they have it and where do they have it? And then what information do we need to answer the question? And once you ask those questions and get a diagnosis, what are we going to do about it? And so the next question is, how are we going to figure out what you have? So there's often tissue is the issue, and we need the morphology, which is looking under the microscope. We look at immunohistochemistry, which are these stains that we may have talked about, and some other fancier techniques like FISH and molecular, which look at not only the chromosomal changes, but also the mutation changes of your lymphoma. We also look at where do you have it. So certain prognostic markers, which may be based upon blood tests like lactate dehydrogenase and beta-2 microglobulin, radiographic tests, which may include PET CTs or just CTs, depending upon the type of lymphoma, and sometimes bone marrow biopsies, which are taking a sample of the bone marrow often from your hip bone. So types of biopsies that you may be asked to get may be fine needle aspirates, which is our smallest sample that can be done at the bedside. They may be utilized in hard to reach areas, but they're not really good for telling us what type of lymphoma this is when there's 60 different flavors. We often utilize core needle biopsies, which is the hollow needle, which can be less invasive and can be done with ultrasound or CT guidance, but it gives us kind of slivers or small samples, but we can sometimes get the architecture and sometimes get a diagnosis from our core needle biopsies. But most commonly, when it's a new diagnosis, we are trying to ask for a surgical biopsy, which is either an incisional biopsy, which I akin to kind of getting half the slices of the pizza. If it's a medium pizza, 8 slices, an incisional biopsy is like getting 4 out of the 8 pieces. So you leave some of the pizza behind. Usually the pizza that's left, the slices that are left behind is because they're traveling along an important nerve, an artery, or a vein, where it would just be too detrimental to the patient to take the whole lymph node. But an excisional biopsy is like getting and eating the whole piece of the pizza. So these are the 2 best samples. They give the best information that allow our hematopathologist the best odds of getting the right diagnosis. But these do require often an incision and a healing of that incision. So what often our pathologists look at first is an H&E slide, and I hope you can see here just the difference in the size of the cells. So when we're talking about large B-cell lymphoma, what is staring back at you on the microscope are these large cells, versus often our smaller cells, our small to intermediate cells are our more indolent lymphomas, those lymphomas like follicular lymphoma and marginal zone lymphoma and small lymphocytic lymphoma. So I alluded to that there's over 60 different kinds of lymphomas, and this comes from our WHO classification. And if you can think about, we as lymphoma doctors are like transistor radios. We're switching, wavelength as we go patient room to patient room, because we may see a large cell lymphoma, then see a mantle cell lymphoma, then see a CLL, SLL, and we really have to change wavelengths on how we may treat these patients and what our treatment paradigm may be. But for today's discussion, we're going to stay on the frequency of large B-cell lymphoma. So how do you get to the diagnosis of large B-cell lymphoma? Well, not only are you looking underneath the microscope, looking at these large cells, but we may use different stains, which are looking at the antigen, which is a flag on the surface of the cell. And then we use an antibody, and it's kind of gives a little bit of fluorescence sometimes, or stains differently, that may help us see the unique patterns that come in our B-cell non-Hodgkin's lymphomas. And so each of our CLL, our mantle cells, our folliculars can have specific patterns. In our T-cell lymphomas, we actually see loss of some of these antigens rather than a characteristic pattern a lot of times. So I alluded to these stains, and this is just an example. I know it doesn't show well here, but I wanted to show the background of our research center, I guess, here. But it shows you just different stains that can lead to a differential diagnosis of all of the different subtypes of our non-Hodgkin's lymphomas. And so these patterns matter, but they matter in the context of the architecture. So I know this, I'm not trying to make you a secret hematopathologist here, but I also want to give you some context, because nowadays in 2025, patients have a lot of access to their electronic medical records. You may see your path report, unfortunately, sometimes on Friday at 7 p.m. when there isn't often good resource, but some of these markers that you may read about may show up in your reports. And so here, like CD20 is a marker of B cells. CD5 is often a marker of T cells, but can show up often in B cell lymphomas too. And CD30 is a marker of B cell of activation of cells, and may show up in some B cell lymphomas, but is more commonly in our T cell lymphomas as well as in Hodgkin's lymphoma. So really, it is a complex space, and you need all of this information to make a diagnosis. And now, so slicing up the pie and getting to diffuse large B-cell lymphoma. Diffuse large B-cell lymphoma is our most common non-Hodgkin's lymphoma. You can see here about a third of all of the cases of non-Hodgkin's lymphoma are diffuse large B-cell lymphoma, followed closely in second place by follicular lymphoma, which is our most common indolent non-Hodgkin's lymphoma. And you can see some more less common subtypes to the left of this pie here. And so the next question, once you have a diagnosis of large B-cell lymphoma, or in fact, many of our non-Hodgkin's lymphoma, we ask the question of where is it? And that's where our CAT scans come into play. You may be asked about to take an oral contrast, which helps align what are bowel wall structures versus other structures deep in the abdomen area, as well as IV contrast, which IV contrast helps better define the size of the lymph nodes and may help us separate out areas that may be things like an abscess, which is a chronic infection occupying lesion. I always tell my patients, if they're getting IV contrast, you'll get that weird sensation of warmth, and it isn't actually that you're urinating on yourself. It is just the IV contrast going in, and so you get that warm sensation. And if you don't talk about it and it happens, patients say, "Whoa, what is that?" Experience. And so I do talk to my patients about the IV contrast. CAT scans, are looking at a body kind of split up and sliced into many different places here. And so I use Barack Obama as my example here of kind of looking what the lungs look like, what the liver looks like in the upper right category here, and then what your psoas muscles may look like, which is our filet mignon muscles as you get deeper into the pelvis. And when we talk about bone marrows, these are the bones here on the bottom right that we go into to actually get and aspirate or pull back the bone marrow to look at under slides. You also may have heard about PET scans. And so PET scans utilize radioactive sugar that is then injected into you, and then you're put in a dark room and listen to music and relax. And as that radioactive sugar goes and gets eaten up by your cells, glucose is the fuel for our body, and anything that's moving a little bit faster or dividing faster eats up that glucose very quickly, but then gets locked inside the cell. And like a Polaroid picture, is shooting off photons kind of off into this big gamma camera. And as those photons get shot off into this big gamma camera, things light up more often. And this is just a slice of a patient who has had a PET scan. And so this sugar activity or this FDG avidity you hear may show different things. It can show infection, it can show inflammation, but it can also show malignancy. But you also see here that there's this donut-like structure, which isn't lymphoma. That's actually your heart. And this black thing at the top of your head isn't a big brain tumor. It's actually your brain. And what actually is at the bottom here is your bladder, where that radioactive kind of sugar and dye can accumulate, and then you pee it out. But what isn't normal in this location is the black dots that represent the right cervical or right neck region of lymph nodes, as well as a right axillary lymph node or right lymph node underneath the arm. So PET scans are also good at finding other areas and unify what's a kind of a benign process versus potentially a malignant process. So you can see here a nodule in the lung that is active and concerning for cancer versus other conditions. And so biopsies are reasonable, and a type of biopsy may be chosen based upon your history as an FNA, a core, or a surgical biopsy. PET scans are also important before therapy to know where things are at, but they are also important after therapy to define a remission. So here you can see a PET CT with avid lymph nodes underneath the arms and the chest, and the patient received treatment for their large B-cell lymphoma. And this may show a complete remission after treatment, but we have to take that complete remission into treatment because certain things like prophylactic growth factor use may lead to diffuse kind of uptake within the bones. And so that's our job as the oncologist or the lymphoma expert to know the timing of when to do the PET scan and how to interpret the PET scan into context of what you're having done to you, the patient. All right. So staging of lymphoma is incredibly important because it can determine how we treat you or for how long we treat you. So when we talk about staging, the Ann Arbor staging is what we've classically used, now called the Lugano staging over time. But if you have your lymphoma in one area or one station, that is called stage 1. If you have your lymphoma in 2 lymph node stations, either above or below the diaphragm is what keeps your lungs where your lungs are supposed to be and your guts where your guts are supposed to be. If you have it above or below the diaphragm only, that's stage 2 disease. If you have lymph node stations above and below that diaphragm, then it's stage 3. And if you have it in any lymph node, but also have it in an organ like the liver or in the bone marrow, that is stage 4 disease. And so I think it's incredibly important to realize that lymphoma staging is different than pancreatic cancer or lung cancer staging, and it certainly has different ramifications with regards to treatment, because many times we can still cure stage 4 large B-cell lymphoma. So I come back to the classifications, knowing that I wanted to level set kind of how we get to the diagnosis of these many different subtypes of non-Hodgkin's and Hodgkin's lymphoma. But now we're going to key in on our large B-cell lymphoma. And I think as we dive deeper into our diffuse large B-cell lymphoma, to know that we still use stains to help separate out what is a non-GCB or non-germinal center large B-cell lymphoma versus what is a germinal center B-cell lymphoma, with the overwhelming majority of our large B-cell lymphoma still coming from a GCB subtype or germinal center B-cell type, and the minority being a non-GCB. Then many of us still use the IPI score because it's still in play in our prospective clinical trials, where we utilize factors like your age, your performance status, which is kind of how you're doing in regards to your lymphoma, as well as your other comorbid conditions. We use blood tests like LDH to see if it's above our upper limits of normal on a blood test. We use your scans to define not only if there are extranodal sites of disease, like in the bone or the liver, would be 2 sites of extranodal disease. And then your stage, so stage 3 or stage 4. And you add up all these 5 points, and it helps define prognosis, also based upon not only your subset of your lymphoma, but also your IPI score, which helps us define kind of the risk benefit of certain, not only intensity of therapies, but also number of therapies to be given. All right, so it's time for treatment, and I'm doing pretty good on time because Hope used 5 minutes of my time at the beginning, so I get 5 minutes extra here as I get to 25 after. All right, so here's what we want to do in large B-cell lymphoma. We are trying to carve a space where we try to get to the green people here, understanding that all patients with the same diagnosis won't respond to our therapies. So we're striving to 100% benefit with no toxicity, but we're not there yet. In oncology in general, we have very few therapies that work 100% of the time and have 0% toxicity. But really what we're trying to get to is benefit with acceptable toxicity. And we really don't like therapies that drive no benefit and have toxicity from that standpoint. And so we've been trying for 2 decades to continue to improve upon R-CHOP therapy, which goes all the way back to 2020 or 22, 2000, 2001, 2002. There we go. Where R-CHOP or rituximab finally improved upon CHOP. And then for 20 years, we were doing clinical trial after clinical trial trying to beat R-CHOP. And we finally did that in the POLARIX trial after nearly 15,000 patients with large B-cell lymphoma going on to randomized trials with a POLARIX trial, which introduced POLA-R-CHP to the community of treaters for large B-cell lymphoma. And it was done in this randomized double-blind trial, which was the best of the best trial design. So I didn't know as the oncologist, you didn't know as the patient if you were getting polatuzumab or vincristine. And vincristine is a very old drug. Polatuzumab is a very new drug that was an antibody drug conjugate. So it delivered the chemotherapy to a cell that expressed a flag called CD79B. So you can see some of the key criteria here. It was all stages. You had to have an IPI score of 2 or 5. You could not have had prior treatment, and you couldn't have had an indolent lymphoma that became a large cell lymphoma. So everybody got 6 cycles of either Pola-R-CHP or R-CHOP, followed by 2 cycles of rituximab. And what we saw here is that it met its primary endpoint of progression-free survival at 2 years. You can see here at the bottom that with the 3-year and the 5-year update, there continued to be an advantage for Pola-R-CHP. However, there was no overall survival advantage, but we still called this a positive trial because it met its primary endpoint. But we then asked, is there patients that maybe we should try harder or really consider this treatment in? And some people did that, and some people like myself just maybe considered this for all populations who met the clinical trial criteria. But certainly in this ABC or active B cell subset, those Pola-R-CHP patients appeared to do better with regards to 2-year progression-free survival, meaning they were alive and progression-free at 85% versus 56% if you're ABC subtype. But there were other subtypes that we looked at with regards to higher IPI scores of 3 to 5, age greater than 60. Now, whether or not these held kind of over time, I think as we had more and more therapies, they tended to fall off, except for the subset at the 5-year data set. But sometimes we have to ask at what cost. And so you can see here, peripheral neuropathy was seen in both groups, but equally. And there really wasn't a lot of difference between the 2 groups in a randomized double-blinded fashion to where you could say, well, there was higher toxicity, even though there was still a PFS advantage. So in my practice, despite there being a PFS advantage and not a considerable toxicity difference, I have and started to use primarily Pola-R-CHP. So on to the next generation of what we're doing. We're now adding more novel therapies. And this is a coalition data, which looked at newly diagnosed large cell lymphoma who had IPI scores 3 or higher, or NCCN IPIs 4 or higher, including our double hit patients, high-grade B-cell lymphomas with MYC and BCL2 rearrangement. And in here, a great trial design where everybody got R-CHOP times 1 cycle, and then half the patients got glofitamab, which is a CD3, CD20 bispecific antibody, plus either R-CHOP or POLA-R-CHP. You can see here 80 patients randomized 1-to-1. And look at this, so in order to cure patients, the first step in curing patients is getting into a metabolic CR. And you can see both arms here with the addition of polatuzumab. 98% of them got into a CR. And it really didn't matter here kind of what subsets of whether or not you're GCB or ABC, whether or not you had double hit lymphoma, whether or not you were high IPI, you did quite well. And you can see here small, short follow-up, but patients were doing really well regardless if you were getting R-CHOP or POLA-R-CHP. There was some additional toxicity, though, with the glofitamab, including cytokine release syndrome, but there was no neurotoxicity. So for those of you who have heard about our CAR T cells or bispecific cytokine release syndrome, can manifest as just as simple as a fever, but sometimes could lead to shortness of breath, as well as low blood pressure. And so I think we have to balance out here some of the toxicity versus benefit here. But we're looking at this in kind of the next hot trials. And I think the SkyGlow trial is one of those hot trials that we're accruing to in a randomized fashion of POLA-R-CHP versus glofitamab POLA-R-CHP in a 1-to-1 trial. And there's some other hot trials kind of going on. And so there's not a shortage right now of great trials in the frontline large B-cell lymphoma space. CAR T cells are being tried in the Zuma 23 trial, which is the upper left-hand trial. The Frontline trial is bringing forward tafasitamab lenalidomide, so a CD19 antibody against R-CHOP. The EPCO trial is using another bispecific antibody against CD20 with R-CHOP as its comparator. And lastly, but not last, is golcadomide, which is a new targeted therapy, and that's going up against R-CHOP versus placebo. And so I think I left and it did it almost on time for Dr. Johnson to take us further through the large B-cell lymphoma landscape. So I'm going to pass the joystick over to you to land this plane. Dr. Johnson.
Thank you so much, Dr. Lunning, for your presentation and for kicking us off today. And I'd like to formally introduce our second speaker, Dr. Connor Johnson. Dr. Johnson is a hematologist oncologist at Massachusetts General Hospital, as well as an assistant professor of medicine at Harvard Medical School. He's also a former foundation scholar as part of our Lymphoma Scientific Research Mentoring Program. And again, we're thrilled to have him on the program today. So Dr. Johnson, I'll turn the talk over to you.
Thank you so much, Hope. And I got to say, it's always tough to follow Dr. Lunning. So this is not an easy task that's been assigned to me. I'm going to share my screen, and then Hope, if you don't mind, just verifying for me once I do so that you can see everything. And then I'm going to put it into a presentation mode. And I think I need to flip so that everybody can see it. Does that look good?
I think you have to flip it back. I think it was right the first time.
All right. That looks good.
Looks good. Yeah.
Fantastic. So I'm absolutely delighted to be here. As Hope mentioned, I've had the privilege of being involved with the Lymphoma Research Foundation as a scholar in their mentoring program. And I am an assistant professor of medicine at Harvard Medical School and practice as a lymphoma specialist at Massachusetts General Hospital in Boston. So I'm going to get a chance to pick the baton off from where Dr. Lunning had taken us and now take a look into second and third line treatments for diffuse large B-cell lymphoma. So thinking about, what if POLA-R-CHP or R-CHOP unfortunately don't completely eradicate the lymphoma as we hope. So let's dive into that. This slide here shows my disclosures. And so let's begin with an overview. And I hope that this is both helpful and practical as we go through each part of the landscape. So this is a nice little slide that basically gives an overview of how I approach any patient who's coming to see me where we have seen return or incomplete eradication of diffuse large B-cell lymphoma with the first treatment approach, which is typically going to be R-CHOP or POLA or CHP, as Dr. Lunning outlined. So historically, we used to use another barrage of chemotherapy for really everyone who we saw whenever diffuse large B-cell lymphoma returned. But that's changed dramatically over the last few years. So now when I see a patient, the first question I'm going to ask is, did the lymphoma return early, meaning within the last 12 months since getting that first-line treatment, or later on, meaning after 12 months? And that's what the term relapse refers to. Relapse really means that the lymphoma went into remission and comes back. Refractory means that that first-line treatment just didn't eradicate the lymphoma. So a scan, like a PET scan that Dr. Lunning outlined, demonstrates that the lymphoma has not been eradicated with that R-CHOP or that first-line treatment. For patients where the lymphoma is coming back early, our standard for the vast majority of patients is actually to use a treatment called CAR T-cell therapy. And we're going to talk all about that on a subsequent set of slides. And we have 2 CAR T-cells that are FDA approved in that situation. For patients that have later relapses, meaning more than a year out after chemotherapy, chemotherapy often can work very well, again, in this circumstance. And so we modify the chemotherapy approach and then add in something called an autologous stem cell transplant, which again, we'll go through in much greater detail on a subsequent slide. But I want you to sort of have a sense that really that time from receiving first-line treatment to when we see the lymphoma present again dictates how we want to personalize treatment in the second-line setting. All right, now let's go into CAR T cells first. So CAR stands for chimeric antigen receptor. And this is really immunotherapy. It's a form of treatment where we take a patient's own T cells, which are white blood cells that have a role in the body in fighting infections and aberrant or abnormal cells, and we genetically change them or engineer them to express a target or latch for the cancer, for the diffuse large B-cell lymphoma. And that latch I'll show you on the next slide. And this is really honing and harnessing the power of the body's own immune system to try and treat the diffuse large B-cell lymphoma, as opposed to treating it, with chemotherapy. And we have 3 fully FDA-approved, well-tested CAR T-cell products approved for relapsed refractory diffuse large B-cell lymphoma, and well over 100 and counting clinical trials further assessing this treatment both in diffuse large B-cell lymphoma, other lymphomas, and even other types of cancer. And Dr. Lunning highlighted one of those trials in sort of upfront or first-line treatment of diffuse large B-cell lymphoma. So, what is a CAR T-cell? And remember, CAR, like driving a car, is what we abbreviate or refer to. And this little schematic tries to overview that. We have the normal T-cell represented by the box at the bottom. And using typically a virus, we change the DNA of that T-cell to express a latch, something that can bind to CD19 typically, which is a protein on the outside of the diffuse large B-cell lymphoma. And this is allowing a better mechanism to recognize that cancer cell. Because remember, these cancer cells are altered versions of the body's own healthy cells, and so are really quite good at hiding themselves or cloaking themselves from the immune system. This is basically teaching the T cell a better way to recognize the diffuse large B-cell lymphoma. And this allows more rapid and efficient activation of the immune system to hopefully eradicate the cancer cell. So why do we, what's the evidence base behind why we like to use CAR T cells typically for most patients with an early relapse? Well, 2 separate large randomized controlled trials that were designed in a similar way to what Dr. Lunning showed with the Polarix trial, where half the patients got CAR T cells and half the patients got standard historic chemotherapy. So kind of our typical one-size-fits-all approach. And in these trials, patients had the lymphoma returning within 12 months of treatment, hence that outline that I gave you on the prior slide. And the patients who got CAR T cells did better. And they did better, meaning they were more likely to be cured of their cancer, and they were more likely to be alive and well. In other words, actually alive when they received CAR T cells. And so this provides the evidence base to support CAR T cells in this situation. And the two that are approved are axicabtagene ciloleucel, or Axi-cel, or trade name Yescarta, which you may have seen, and lisacabtagene maraleucel, or Liza-cel, or Breyanzi. And in the third line and beyond, meaning after 2 prior lines of therapy, another CAR T cell called Tysogen lechlucel, or Kymriah, also has FDA approval based on a large clinical trial. So that's why we have 3 FDA-approved products for diffuse large B-cell lymphoma. So, I mentioned that CAR T cells are different than getting chemotherapy. So let's dive into that in a more detailed fashion. So remember, this treatment is actually using the patient's own T cells. So as opposed to just prescribing a medicine, we actually have to obtain a portion of the T cells from the patient. And that's the first step, called leukapheresis, meaning collection of white blood cells. And this is a process typically where an IV, a catheter that looks like an IV, is placed in the arm or the neck. And then a patient is hooked up to a machine that filters out a small portion of the T cells, typically over an approximately 4-hour period. It looks a lot like donating blood. If you've ever seen people donate blood, that's very much what it physically feels and looks like. And so patients tolerate this beautifully with very little, if any, side effects during the process. Then, after these T cells are collected, they must be manufactured. In other words, the bionic or CAR T cells must be created. And that process takes approximately 3 to 4 weeks typically. And in that process, they're going to create the CAR T cells, typically using a virus to engineer that latch I talked about, and then make sure that it's the proper number of T cells and that the characteristics are appropriate in order to infuse them back into the patient. Then once these T cells are ready, they're going to be sent back to Dr. Lunning, who prescribed these T cells, and he's going to receive those and then administer those CAR T cells. But first, he or myself, depending upon where you're being treated, will give 2 or 3 days, typically 3, of some chemotherapy to lower the patient's white blood cells so that the CAR T cells will flourish, much like making space in a garden, so to speak, as a metaphor. And then the CAR T cells are given as a single infusion because remember, they are a living drug. These are your own T cells that have the capacity to grow and proliferate on their own, which is very different from, say, prescribing R-CHOP. Now, this is the same sort of set of steps, but maybe broken down as a patient journey, kind of step by step, what you might think about as you go through the process. As I mentioned, the first step is going to be meeting Dr. Lunning or myself or another CAR T cell specialist who will do a consent process and talk to you all about all the things that we're overviewing today. Then the next step will be the collection of the T cells, which is that leukapheresis process. Remember, because it might take 3 to 4 weeks to make the CAR T cells, some patients will require some treatment to control the cancer during this time period. Because you might be wondering in your head, what am I going to do for 3 to 4 weeks if the cancer is just sitting there? And not all patients require treatment. Sometimes the patient's lymphoma is already under good control. But when we do give treatment, we call that bridging therapy, sort of building a bridge to the CAR T cell treatment. And that can take the form of multiple types of treatments. It can be radiation therapy to a particular site. It can be steroids, which can be given for a short period of time, or most often an intravenous medication, maybe polatuzumab, like Dr. Lunning pointed out in the Polarix trial, or some traditional chemotherapy. And the goal is to keep you well and healthy and the lymphoma under control until the cells are ready. Then when the CAR T cells are ready, the patient receives that 2 to 3 days of chemotherapy. Common side effects of that are fatigue, nausea, and diarrhea, typically very manageable with the proper supportive care. And the CAR T cells can be given either in the hospital, in which case it's typically a 1 to 2 week hospitalization for monitoring of side effects, or in some cases in the outpatient setting. And that's typically decided upon with a patient and their doctor together, thinking through based on their clinical situation and which CAR T cell they're receiving. After the patient is ready to leave the hospital, or throughout, if done outpatient, there'll be careful monitoring in clinic for the first 4 weeks after treatment. And there typically are requirements to stay close to the hospital, for our center within 30 minutes, but every center can be a little bit different about the exact amount of time. And you have to have somebody with you 24 hours a day, 7 days a week for those first 4 weeks. And we refer to that as a caregiver, but it's mostly to have a phone call if anything is going wrong, so we can make sure that the patient is seen quickly or expeditiously if there are any side effects that emerge. And then after that first month, we repeat a PET scan to assess response and begin the process of survivorship monitoring. And most programs will suggest 8 weeks of no driving during this CAR T cell treatment time period. Now, why is that? We gave an overview of some of those logistics. So let's talk about the side effects that can occur with CAR T cells. Dr. Lunning mentioned some of these when he was talking about glofitamab in the clinical trial. One of the most common side effects of CAR T cells is called cytokine release syndrome, or CRS for short. And this is a flu-like inflammatory illness related to the CAR T cells trying to treat the cancer and secreting chemicals of inflammation, because this is an immune therapy. This works by the immune cells secreting the chemicals of inflammation they're supposed to try and eradicate the cancer. The goal of this treatment, by the way, is to cure the cancer, meaning get rid of it permanently. The most common symptom of cytokine release syndrome is a fever, which all patients experience. And other symptoms that are common are things like muscle aches, chills, fatigue, loss of appetite, joint aches, maybe a headache. Less frequently, patients can have low oxygen and low blood pressure, and rarely patients can have injury to their organs, and very rarely require monitoring in the intensive care unit. That is less common. Most of the time, this can be managed with things like intravenous fluids, an intravenous medicine called tocilizumab, and sometimes corticosteroids, which are steroids like given with the prednisone in CHOP. The second main side effect of CAR T cells is called neurologic toxicity. And similarly, this occurs because of the inflammation generated by the CAR T cells. The common symptoms are some confusion, maybe trouble with writing or speech or remembering certain words, or some tremors. Rarely, patients can have more serious symptoms like a sleepiness that we refer to as somnolence, or seizures or brain swelling. And rarely, patients can require being in the intensive care unit, though again, that's uncommon for these two side effects, but because of that rare potential, this is the reason for some of the precautions and the careful monitoring that are established for patients in the first few weeks. The vast majority, almost all patients, this is completely reversible for both of these side effects. And for neurologic side effects, we typically give corticosteroids. I should also add, in some subsequent studies, the vast majority of these side effects occur in the first 14 days, and it's uncommon after the first 14 days for patients to experience these two side effects, which is why the particular time of monitoring is typically in those first 2 weeks. Other side effects we can see with CAR T cells are low blood counts, leading to risk for infection, similar to what you might hear about when receiving chemotherapy. Low immunoglobulin levels, which are proteins that are generated by B cells and other immune cells to help fight infections. And then rarely, patients can have a very hyperinflammatory syndrome that's called immune effector cell associated hemophagocytic syndrome. And again, that is very rare, but that's a hyperinflammation that requires corticosteroids and an anti-inflammatory treatment called anakinra. And there have been reports, and typically in the low single-digit % risk, of second cancers after treatment with CAR T cells, although that's also true after chemotherapy and many other cancer therapies. And I want to emphasize again, this is a rare side effect of CAR T cells. Now, what's the overall experience like? This is a quality of life study that I ran with some colleagues, where we took patients receiving CAR T cells for lymphoma and a blood cancer called multiple myeloma, and followed their quality of life longitudinally. And I should add, this is similar to what's been seen in some of the pivotal clinical trials of CAR T cells. And what we found is that quality of life took a dip down in the first 2 weeks as they're going through these side effects, and then typically rebounded by the 1 month time period, and actually overall on average improved by the time you were 3 months out from CAR T cells. And that raw number was similar to the average US population quality of life, which I think is very reassuring. And we didn't find any factors associated with a negative trajectory of quality of life. So in other words, most of these overall quality of life experience side effects do tend to improve with time. Now that is a broad overview of CAR T cells, but what about later relapses when we're giving chemotherapy and potentially the stem cell transplant? So let's talk about that as well. So remember, for later relapses, this suggests that chemotherapy worked well, just not all the way to what we wanted, which is cure or full eradication of diffuse large B-cell lymphoma. And so chemotherapy of a different sort can still be highly effective and potentially cure the diffuse large B-cell lymphoma. Several different chemotherapy regimens are available, some of which might be RICE, which is a 4-drug regimen given inpatient or outpatient, RDHAP, which is a 4-drug regimen given typically inpatient, and RGDP, which is a 4-drug regimen given outpatient typically. The side effects of these regimens are honestly pretty similar to chemotherapy side effects that you've probably read or heard about from R-CHOP or POLA-RCHP. Low blood counts with risk for fever and infection, fatigue from low blood counts typically potentially requiring blood transfusions, nausea, risk of hair loss, gastrointestinal side effects like diarrhea and constipation, and neuropathy or numbness and tingling in the hands or feet are very common symptoms experienced by patients. Commonly, a lot of these regimens are given on a 3-week schedule, which is referred to as a cycle, and typically 2 cycles or 6 weeks of therapy are given, and then a PET-CT is repeated. If the PET-CT, which Dr. Lunning outlined, shows a remission, especially a complete remission, meaning no evidence of lymphoma on the scan, then we typically give 1 more cycle of that treatment and then move to an autologous stem cell transplant, which I'll talk about on the next slide. In contrast, if the PET scan doesn't show what we hope it shows, often patients can then move to CAR T cells. So in other words, just move to CAR T cells in the 3rd-line setting. So the CAR T cells absolutely remain available for this patient population as well in the event that this treatment doesn't work the way we want it to. For a subset of patients, maybe because of age, for example, this treatment is often given to patients younger than 70 years of age. The transplant may not be the treatment that's best for you or could have higher than desired risks of toxicity. And so CAR T cells remain an option potentially for patients in that scenario. So just because you have a later relapse and you're not able to get a stem cell transplant, that doesn't mean you can't receive CAR T cells, which are absolutely studied in that specific situation. Now, what about the transplant? Let's say that it shows remission and the doctor wants to move forward with the next step, which is the transplant. There are different types of stem cell transplants. And so here are the different forms that we think about. Autologous means a transplant where we give stem cells or basically the baby cells of white blood cells and other types of blood cells from the patient. So that's from self, which is what auto refers to. Allogeneic transplants are where we give the stem cells from another person. So auto would mean my own cells, whereas allogeneic might mean if Dr. Lunning's cells were used for me. In a very specific scenario, if you have an identical twin, there's a synergic transplant, which means the cells are from your identical twin. So what are the steps with a transplant? This is basically in concept a way to give a single treatment of very high dose chemotherapy and then to give back stem cells to allow recovery of the body's healthy cells. So it's a way to give a high dose chemotherapy treatment to try and eradicate the diffuse large B-cell lymphoma or cure it. So the stem cells are collected, the patient receives a treatment of high dose chemotherapy, and then the stem cells are given back. And in terms of steps and what it looks like, this is typically a rough framework for how it's done. The hospitalization, there are some places where it's done as a sort of outpatient setup where you're seen every single day. But a lot of centers will do these transplants entirely in the hospitals, and that's true for our center. And people are usually hospitalized for about 3 weeks, where they'll receive the high-dose chemotherapy, the stem cell rescue, be monitored for recovery, often receive some antibiotics and transfusions or blood products during that period, And then as they make a blood count recovery, then they'll switch to outpatient monitoring. And as they make a more full immune recovery, then there'll be a program of revaccination in order to try and rebuild immunity. Common symptoms of the chemotherapy and transplant, and particularly of the transplant, are listed here. Similar to chemotherapy side effects, though typically a little bit more extreme because of the degree of the dosing of the chemotherapy. Patients are typically tired, have risk for fever and infection, low blood counts, hair loss, mouth sores, nausea, vomiting, appetite loss, and diarrhea. I will note that this treatment for younger patients does have a much higher risk of infertility than, say, R-CHOP or POLA-RCHP. So for younger patients, it is often very important to have a discussion around fertility and consider a fertility consultation when going through this process. Now, with our last few minutes, let's talk about third-line treatment, by which we mean if it's a scenario where the patient has received 2 different types of treatments and unfortunately, the lymphoma has still not been fully eradicated. So let's say a patient received R-CHOP and then also received chemotherapy. CAR T cells, as we mentioned, remain a standard option in this scenario if they haven't been given before, but we have actually quite a few other innovations. So actually everything in blue here, which is essentially the whole slide, except for the part on the far right that says chemotherapy, has been pioneered over the last essentially 7 to 8 years, which is really quite remarkable and a transformative thing for doctors and patients. I want to highlight that we're going to spend a little bit more time talking about epcoritamab and glofitamab, but polatuzumab, which Dr. Lunning talked about, tafasitamab, which is an antibody to CD19, loncastuximab, which is an antibody drug conjugate to CD19, brentuximab vedotin, which is an antibody drug conjugate to CD30, and a pill called selinexor and ibrutinib are all potential options in these scenarios. But I would say most patients these days in the third line who've received chemotherapy and CAR T cells as first and second are often considered for something called a bispecific antibody. Now, what are bispecific antibodies? And Dr. Lunning did a great job introducing this in the clinical trial that he talked about as kind of the next frontier in first-line therapy. Bispecific antibodies are a common treatment in the third line for many lymphoma specialists. There are 2 that currently are FDA approved for diffuse large B-cell lymphoma in the third line setting, and their names are glofitamab or Columvi and epcoritamab or Epkinly. Glofitamab and sometimes epcoritamab are also available in the second line for those that cannot receive a CAR T-cell therapy or a stem cell transplant. These are off the shelf, meaning the doctor can just prescribe it and give it immunotherapy treatments and have similar side effect profiles to CAR T cells, though typically to a lower degree because the treatment can be held and re-administered, and so as opposed to a living drug. The most common side effects are listed here. I typically see fatigue, some low blood counts, risk of infection, and cytokine release syndrome, and usually that side effect profile, particularly the cytokine release syndrome, is in the first 4 weeks of the treatment. Both of these drugs are approved with a suggestion to have a single 24-hour observation at one point during the treatment course to monitor for the cytokine release syndrome. This is a schematic of what a bispecific looks like. It's got part of the arm that binds the lymphoma on a protein called CD20 and part of the arm that binds your T cells, and it tries to bring them together to activate the T cells against the lymphoma. This is just summarizing a little bit of the glofitamab and epcoritamab and some of the logistical differences between the 2 drugs. The glofitamab is intravenous, meaning through the vein, whereas the epcoritamab is subcutaneous, meaning an injection given into the skin and subcutaneous tissue. And there's some differences in how they were designed in terms of how frequently to give. The glofitamab is weekly for 4 treatments, followed by every 3 weeks for a total of 36 weeks, whereas the epcoritamab is given weekly for 3 months, every 2 weeks for another 5 months, and then every 4 weeks. That said, your doctor is able to guide you about how they think about both of these treatments and what the pluses and minuses might be for you. The last thing I'd like to say in my final 30 seconds is Dr. Lunning highlighted the importance of clinical trials. And clinical trials are research studies that have volunteers that are patients that participate. The goal is always to answer a question about lymphoma. Often, how do we do better with our treatment or make it better than the current standard? And sometimes this can be the best option for treatment, depending upon what you and your doctor feel like, and it can allow access to cutting-edge clinical care. These are carefully regulated, and heavily thought about trials with lots of protections in place for patients. And remember, not all trials involve placebos. And so some of these are studies where everybody gets the assigned treatment. It's important to talk to your doctor about the details of a given trial. And this is a way to potentially help other people as well. So in conclusion, we talked about that there are new standards for how to approach second-line treatment in diffuse large B-cell lymphoma with CAR T cells using axi-cell or lyso-cell. We talked about the unique side effects and logistics of CAR T cells. We talked about later relapses where chemotherapy and an autologous transplant can still be highly effective, and that many options are now available in the third line or beyond, including bispecific antibodies. And I'll highlight this is all really rapidly evolving, which is an exciting time in diffuse large B-cell lymphoma management. And so with that, I'm very excited to rejoin Dr. Lunning and take some questions.
Thank you so much, Dr. Johnson. We do have the remainder of the program for questions. We've already received quite a few, and I do want to remind everyone that we won't be able to get to every question today, and some questions aren't best answered in this format. So if you do have any remaining questions after the program, please reach out to our helpline, and I'll send that information, or I already have in the chat for you. So starting off with some questions on the basics for Dr. Lunning. Is there a difference between DLBCL and LBCL? What does the diffuse part mean?
Yeah, I think that this has gotten into a bit of a uncomfortable zone. I call it large B-cell lymphoma because it just is more of an umbrella term, and diffuse large B-cell lymphoma, not otherwise specified, has become kind of a subset of large B-cell lymphoma. There are many different less common subtypes of large B-cell lymphoma. For instance, Dr. Johnson and I referenced high-grade B-cell lymphoma with MYC and BCL2, or which has historically been called a double hit lymphoma. So there's different subsets that kind of, I think of it, fall underneath the umbrella term of large B-cell lymphoma from that standpoint. So they're typically one and the same, but I just characterize large B-cell lymphoma as kind of the more all-encompassing term.
Thank you. And Dr. Johnson, we had a participant report that after multiple lines of treatment, they received CAR T in January of 2021 and had a complete response. They say that they're currently on an 8-mile walk. And knowing that CAR T has a short history, they're wondering when one is considered cured.
Ooh, that's a very good question. We now have in diffuse large B-cell lymphoma, we historically have used a 5 years being cancer-free as a designator of patients that we think are very likely to be cured. And I think that is a very good marker for cure. So that typically is the time frame that we use when declaring patients cured. I will tell you, relapses after 2 years following CAR T-cell therapy are exquisitely rare from what we understand so far. So we typically still don't use the word cured after 2 years, but that's a very, very encouraging time point for those that receive CAR T-cell therapy for diffuse large B-cell lymphoma. But I think most of us would still use the 5-year mark as being the best barometer of cure. Now, I should add, for patients without diffuse large B-cell lymphoma, so those with low-grade lymphomas that Dr. Lunning referenced, we're still learning what the term cure might mean there. And there is hope one day that we'll be able to cure those lymphomas, but that same milestone is not necessarily applied to low-grade lymphomas.
Thank you. And Dr. Lunning, is there a general connection between DLBCL and autoimmune disease?
Yeah, I made reference to this earlier, I believe, in my talk with regards to kind of autoimmune diseases that can present with lymphadenopathy, like Sjogren's, for instance, which can have very mild lymphadenopathy. Other autoimmune conditions besides Sjogren's, like lupus, rheumatoid arthritis, may have a higher risk of developing lymphoma in their lifetime than the general population. However, we don't quite understand the mechanisms of that, that would put people at risk for that development of lymphoma. I explain it to my patients as living on a spectrum. Autoimmune conditions are an abnormality of the immune system, but what kind of causes them over time to become lymphomas is not well understood. I think that it is just one of those situations that the rheumatologists or your autoimmune specialist that's treating you just needs to be aware of. But we don't often do screening, from that situation, in autoimmune patients.
I have another question for you here, Dr. Lunning. This participant writes, I'm a care partner for my 21-year-old brother, an athlete who's always lived a healthy lifestyle. Are we seeing a rise in lymphoma cases among young people?
I think that's how you define young people these days. I mean, I want to still consider myself a young person, but I know that I'm not anymore when I go skiing. I feel all of my 44, but my mind thinks I'm 21. From that standpoint, I think that we have to compare biases over time. There are some of our aggressive lymphomas that will manifest themselves within weeks to months of kind of the abnormalities being seen. But there are indolent lymphomas, what may not manifest themselves for years from that standpoint, and that lead time bias that can exist from a person who may have had this for years. If you say 30 is old and 20 is young, from that standpoint. And so I think we have to keep in mind when we see incidences, from that standpoint, going up, there may be that bias. But I'm not necessarily thinking that there is inherently a underlying cause if that incidence is going up that we can identify. I think that certainly we've tried to identify certain things like smoking from that standpoint. I know that there's questions about certain exposures. I do talk to my patients who have been, in the military, that have been at Camp Lejeune if they were Marines, Agent Orange exposures if they were in Vietnam. And now I'm talking to my patients about burn pit exposures in regards to the Gulf War veterans. And so I think that those are things that are being well studied, but to say that there's in particular, an incident or a cause to our younger population, I think the jury's still out in that category.
Thank you for that thoughtful insight, Dr. Lunning. And Dr. Johnson, we did have another question come in. If you're outside of the 12 months of relapse, are you completely exempt from accessing CAR T as a second-line treatment?
A great question. So absolutely not. So one scenario where this might happen is, let's say that you have a medical condition or that they're based on age, that your doctor and you are worried about the side effect profile of an additional chemotherapy and a stem cell transplant. CAR T cells, specifically with lisocabtagene maraleucel, are FDA approved for second-line therapy for those not eligible for a stem cell transplant. And so that indication is pretty broad and can be applied for patients in a variety of scenarios. If you're eligible for both treatments, I would say a lot of physicians will still lean towards chemotherapy followed by an autologous stem cell transplant, but that does require a very careful assessment of the risks of chemotherapy and the transplant with the patient and the provider. So that's where it may be a careful risk assessment of those two treatments if both are an option for you. I think if all those treatments are available, a lot of times folks will start with chemotherapy and the autologous transplant, again, with a careful PET-CT monitoring to always be able to adjust if things are not proceeding as we plan or hope for, to pivot to CAR T cells as another terrific option.
Another question here on CAR T for you, Dr. Johnson. If patients have to stay close to the hospital for 30 days after CAR T, how close is close?
Yeah, that is a great question. Technically, there can be a little bit of differences at different places for how they interpret close. Dr. Lunning and I practice in different specific regions of the country. Boston is difficult to get into, and so we like people to be 30 minutes away, and we'll typically try to work with the CAR T cell company to arrange for hotel stay if the patient doesn't live very close to Boston. But typically the FDA label is 2 hours. So there is a little bit of center differences about exactly what they may feel is optimal for safety of the CAR T cell. Because in general, what we want is if there is a side effect that we see the patient and not that they're going to another hospital other than where the CAR T cells are being administered. And so depending upon where you are in the country, that may guide where things are. Dr. Lunning, I'm not sure what your exact time frame is for your center.
Yeah, I think that we have a similar, well, we have different problem in that we would look, if it's 3 a.m. on a Sunday from Omaha to Des Moines, it's a lot different than if it is 5 a.m. on a Friday, and so it's not always how the crow flies. It's sometimes time specific from that standpoint. I know the label says 2 hours, but I think there's been some variability in that from that standpoint. So yes, the label and how we utilize that sometimes can differ.
And stay tuned. This may change a little bit. There certainly are some CAR T cell companies that are trying to rethink in coalition with the FDA whether the 4-week or 30-day requirement should be shortened to a 14-day requirement. That has not happened yet, but there certainly are some that have argued for shortening the length of time that is required for the 24/7 caregiver and the very, very close monitoring in terms of distance.
That's being driven by data, I think, around the safety of and the timing of the toxicities from CAR T cell.
Thank you both for your input on that question. Dr. Lunning, is transformed marginal zone lymphoma considered frontline DLBCL?
Yeah, great question. So I think when we talk about transformed lymphomas, I bucket them into two different. Are you a treatment naive transformation, or are you a transformation that's previously been treated? And if you're a transformation that's previously been treated, then you have to ask the question of what you've been treated with from that standpoint. So I often talk to my patients, if you're a transformed marginal zone lymphoma and you've never seen treatment before, then I would treat you as a frontline large B-cell lymphoma patient because you would have been anthracycline naive or doxorubicin specifically naive. And so in those situations, I would treat you like a frontline large B-cell lymphoma with likely an anthracycline-based therapy. But I would also talk to you about that the goal of that therapy is to take away the large cell lymphoma component, understanding that over time, the marginal zone lymphoma component may come back. But certainly the primary intent of the therapy is to take away that large cell lymphoma. Now, if you've been previously treated, let's say you have follicular lymphoma and you received R-CHOP for your follicular lymphoma, and then it comes back as large cell lymphoma, that I think is a different scenario altogether because now you've been exposed to that anthracycline. And so what therapy you may use at that transformation in a previously treated follicular lymphoma would, in my clinic, be different than if you were treatment naive. And so there's different flavors. And I think one of the things that we have to remember even about large cell lymphoma, as Dr. Johnson kind of alluded to, sometimes the relapses can be a retrograde transformation. So we're talking about as a forward to a more aggressive lymphoma. Sometimes you can be treated with large cell lymphoma and the relapse may be an indolent lymphoma, a marginal zone or a follicular lymphoma, which then could be potentially treated differently. So that's why I spend a lot of time talking about biopsies and imaging because sometimes you shouldn't, and we shouldn't assume that a relapse is the same lymphoma when it could be a different lymphoma, more aggressive lymphoma, or even a retrograde transformation to a more indolent lymphoma, which may change your treatment options.
Thank you very much. And we're going to take one last question here. I'm going to direct it to Dr. Johnson. If you're treating a patient who's taking epcoritamab, what are you doing for debilitating joint pain?
Epcoritamab, much like all of the immunotherapies that we've talked about today, can have immune-related side effects. Some of that can be diffuse arthralgias or joint symptoms. I think with any treatment, the first thing you got to do is be thorough and make sure it's not related to something else. A lot of things can cause diffuse joint pains, and we want to be very careful. For example, what if it's a viral infection secondary to being on these treatments? And there's a lot of viruses that can cause diffuse arthralgias. And people who receive these therapies are at ongoing risk of particularly viral illnesses and may also have low immunoglobulins, which could be corrected with IVIG infusions. So that's the first principle, is to be very thorough and not missing other etiologies of that. I think if the physician is convinced that it's due to the drug with epcoritamab, I'll typically try to treat with anti-inflammatories, Tylenol, non-steroidal inflammatories, things like celecoxib that are typically not as difficult on the body. Although, if you really need to, and particularly if the patient is doing very well, we can do holds of the drug and just see if people feel better and try to work to the point that the drug is spaced out. Remember, epcoritamab early on is given frequently, but eventually is spaced out to an every 4-week schedule. So it's really about balancing the side effect, being thorough about the diagnosis, and then trying to see if we can manage it supportively. Corticosteroids can be helpful for all kinds of toxicities related to inflammatory treatments, but we want to be careful about that medication just because it can also predispose to infections.
Thank you so much, Dr. Johnson and Dr. Lunning, for your time today. And of course, I want to thank all of our attendees for joining and for asking such excellent questions. If anyone has any additional questions, or if you'd like to be connected with someone else who's going through the same experience, you can reach out to our helpline. I dropped that information in the chat, but our helpline number is 800-500-9976, or you can email at helpline@lymphoma.org. You can find all of the resources I talked about today at lymphoma.org. But with that, thank you so much again, Dr. Johnson and Dr. Lunning. We really appreciate your time.
Of course. Have a great day.
Take care, everyone.